All right, well, it is 8 a.m. and we are getting ready to kick off grand rounds. And we are delighted to have, actually with the advantage of our virtual grand rounds is we actually can have a panel of speakers for grand rounds from Colorado. And to introduce our special guest speakers is Dr. Blair Golden, assistant professor in hospital medicine.
Thank you so much, Dr. Schnapp. So I'm really delighted to be able to introduce today's speakers, Dr. Marisha Burden and Dr. Angela Keniston. Dr. Burden is a professor of medicine and the division chief of hospital medicine at the University of Colorado. She's also a deputy editor for the Journal of General Internal Medicine. Dr. Burden completed her medical degree at the University of Oklahoma and her internal medicine residency at the University of Colorado. She served as chief of hospital medicine at Denver Health Medical Center before coming back to the University of Colorado in 2017. Dr. Burden currently serves as a principal or co-investigator on multiple grant-funded projects focused on improving patient and workforce outcomes in inpatient settings. She's a co-investigator on the ongoing AHRQ-funded ADEPT study, which is examining how to improve diagnostic processes and reduce hospital errors. Alongside Dr. Keniston, she is a co-PI on an ongoing project focused on using the EHR to characterize hospital clinical workload and physician well-being that is funded by the AMA. Dr. Burden has received numerous awards and honors, and I can't highlight them all, but a couple that I wanted to quickly mention include national awards from the Society of Hospital Medicine for her clinical leadership and research, and the double AMC GWIMS Award for emerging leadership. Next, I will turn to Dr. Angela Keniston, who is an assistant professor and the director of data and analytics within the Division of Hospital Medicine at the University of Colorado. She completed her MPH and a PhD in clinical science at the University of Colorado. Her research is focused on using data analytics to improve patient outcomes and clinician teamwork and well-being. She is the site PI at Colorado for the ADEPT study. Dr. Keniston is a widely recognized research leader within hospital medicine. She serves on multiple national committees. A few accomplishments that I would like to briefly highlight is that she co-leads the workforce work group for the Hospital Medicine Reengineering Network, or Home Run. She also co-founded and directs the National Hospital Medicine Writing Challenge. She and Dr. Burden are co-founders of Gritty Work, which they will be talking more about today. And with that, I will turn it over to Dr. Keniston and Dr. Burden.
Great. Thank you, Dr. Golden, and thank you all for the invitation today. We're really excited. And I'm going to jump to our slide. So we're thrilled today to share with you really what I would call is our passion, which is breaking new ground and how we can start to think about to use science to improve the ways we work in healthcare. You met us, so I'm going to skip this slide. And these are just our quick notes of gratitude for the different entities that have funded a lot of the work that we'll share with you today. So we have 3 objectives. We want to explore with you what clinical operations science is and why it really matters for healthcare quality, safety, and efficiency. We'll share a framework for designing and implementing effective workplace practices. And then lastly, we'll explore how to leverage data to improve daily work and build the future of work. If you can't tell, we love thinking about work. So, all right, so we're going to jump into what I call the $11 million problem. Now, $11 million is a little bit arbitrary because it really can mean any dollar amount. And I'll share with you what this problem is, because whether you're a hospitalist, a primary care clinician, we all face it. And my $11 million problem, at least in my mind, was actually a $12 million problem. And I've been in leadership roles and have had to kind of deal with budget negotiations for hospitalist staffing for many, many, many years now. And one of the meetings that really was probably the worst point in my career, where I had what I call the worst meeting of my life, the $11 million problem meeting. And as I walked into this meeting, trying to advocate for resources for my team, I was going in and with a lot of persistence. And they always say that your greatest skill set can be also your greatest weakness. And that is certainly my case in persistence. So I was on my about 20th time trying to get resources for my team. And as I walked into this meeting with my counterparts, and in my world, I have many bosses, and we walked in, and one of my counterparts was just steaming mad. And I was thinking, gosh, that must have been a really horrible meeting that they just came from. But little did I know that anger was about to be directed at me, because I was asking for about $11 million more than they thought I needed. And this question gets at, what do you really need to effectively staff a clinician group, whether it's in the hospital or a primary care setting or a proceduralist, whoever it may be. I came in with my opinion, they came in with theirs. Who's right? And that's really the conundrum that we often face. What do we really need? And how do we know who's right? So it led at one point in my career, what I call like a midlife career crisis, where I decided to go get my MBA because of this conundrum, because I just thought we kept thinking about the problem wrong. It's not bad people that I'm dealing with, but we're all thinking about the problem very differently and with very different perspectives. And what I took away from those 2 years of school is that we often look at a budget in a very simplistic way. We look at it in a very bottom line, short-term kind of way. And when we look at budgets with people as a line item and do this inaccurate accounting, there are actual costs. And we forget to incorporate those costs when we think about how we build our staffing models. And when we get it wrong, it causes patient harm, causes workforce harm. And I believe now that I can firmly say with my MBA in hand that it causes organizational and financial harm. So we're going to jump into something called clinical operations science, which really changed my worldview over my career. And I'll share with you what it is and what it can do to help us think about how we improve healthcare delivery and outcomes. So I want each of you on this call, all it looks like 88 of you, to think about how do you apply science or evidence-based approaches to your everyday work. Now, I know some of you, I don't know all of you, but I would guess that every single person on this call uses evidence-based approaches, no matter what it is you do, whether you're a hospitalist treating cellulitis, if you're in the outpatient clinic, thinking about how you're going to treat your patient with diabetes. We have an abundance of evidence. And in fact, it's almost an overwhelming amount of evidence that grows by the day. But I would ask each of you on this call to think about, how do you think about evidence-based approaches? And do you have them when you think about your staffing models or your work design? So when a team in the hospital setting has 18 patients, is that an evidence-based approach? Or how big is your panel size? And when I've given these talks in the past and asked this question, I ask folks to raise their hands and ask if they have evidence-based approaches to their staffing models. I've yet to have a meeting where somebody can raise their hand and say, here's the evidence-based practice that we have implemented. So we have a lot to learn and a lot to do. So I first found my first foray into clinical operations science when I started out as a hospitalist way back in the day at a lovely safety net hospital called Denver Health, a hospital that's here locally. And the dream back then was to build an academic hospitalist group. And we had 10 or less hospitalists. And I had my mentor, who also was the chair of medicine, Dr. Richard Albert, who actually is still my mentor today. So 17, 20 years later, still going strong, helping me think about tough problems. But back in the day, and he knows that I think this, that he used to be very scary and intimidating. And the expectation was that the hospitalist would meet with him every single month to pitch an idea. And so I desperately did that, one, to not get fired, and two, to hopefully come up with some kind of idea so I could actually be an academic hospitalist. And after about a year, year and a half, maybe 2 years, I finally found an idea that didn't get struck down. And it came from the concept of what an entire country had done. An entire country, it was the UK, implemented the bare below the elbows policy. And there was uproar because people were like, this is not an evidence-based practice, yet an entire country is implementing this. So all clinicians were required to not wear a white coat that went below their elbows, no jewelry. So that conundrum really prompted like an interesting question that my mentor and boss actually liked. And so we pursued a study with no resources, just a lot of blood, sweat, and tears and a lot of teamwork, and embarked on a randomized controlled trial looking at newly washed scrubs compared to white coats in their usual state, which is actually dirty. People don't actually wash them very often, it turns out, at least in that study. And what we found at the end of an 8-hour workday is there was no significant difference whether you had a newly washed uniform or a dirty white coat. And that sparked a lot of interest. So an entire country implemented a policy that didn't seem to have any evidence from it. And I called this the little study that could, because I was like, gosh, if this is all it takes to get into the Wall Street Journal and to have people listen to us, then we have a voice, and we can use that voice to start thinking about tough problems. So there were many tough problems in between that study and this study, but I think this highlights how we can think about our processes. And so when I was an earlier, more junior hospitalist, I would go to hospitalist conferences, both locally and nationally. And I was in shock that there were very few women speakers. And it bugged me. And so I would go to these conferences and I would do my own little assessment, and I would see that there were disparities. And so we decided to undertake a study that looked at, is this just my opinion, or is it actually a pervasive problem in our field? And what we found is, whether it was authorship, leadership, or folks who were speaking at national conferences, there were disparities in a field that was newer. They still had the same problems that fields that had existed for decades. It was the same problem. And then interestingly, in taking advantage of kind of a natural experiment, the Society of Hospital Medicine started implementing open call processes. And so we decided to ask the question, if you implement an open call process, does it actually reduce the disparities? And it turns out it does. So this is just an example of operations science, where you can see how a decision actually influences outcomes. So this is the last study I'll share in this little bit of our talk. But the next question that came was around a hot topic in the field of hospital medicine, and really probably anybody who works in the hospital setting, around early discharges. Now, as a hospitalist and then also division head or a leader in a group, this is a tough nut to crack. And so there are so many things thrown at this problem, such as mini huddles, discharge before noon, geography. Trying to manage workloads is rarely addressed, but it is a strategy. And then incentives, and all come with differing opinions on how effective they are. And I will own that I have been one of those leaders who have sent those texts or emails that say, hey, did you know, by the way, busy clinician, that it is busy today, and that we would like you to discharge 1 or 2 patients before noon, not realizing perhaps the harm that that might cause. And so with all that stress around early discharges, and then at some point I was like, I think these strategies are not working. Let's actually study it. And so a pervasive strategy across not only the United States, but the world, we decided to test in a randomized controlled trial. And this one we actually got funding for. And what we found, no matter how you slice the data, there was no significant difference on length of stay. So this tactic that is used in almost every hospital, probably every hospital across the US, does not work. And then what we found, if you look in the upper right-hand corner, I really love this all caps comment, irritated that I rounded on the discharging patients first, knew they wouldn't be able to leave, and it caused rework. And so something that not only doesn't work, but may actually cause harm. So why does clinical operations science matter? I've shared with you some examples of how we can start to think about it to help you think about how we define it. But why does it matter? And I would argue it matters now more than ever, because across the United States, probably across the globe, and hospitals across any place you're at, there are conflicting goals. People perceive that folks feel that they're understaffed. There is a lot of burnout. What are productivity goals? How should we incentivize? There's a lot of differing goals. And then to add fuel to that fire, we have limited resources. So we have to make tough choices. And then lastly, which just really makes decision-making hard, is there is uncertainty. So when you're trying to plan for next year, we don't actually know. And then we often make bad decisions when you have that combination of conflicting goals, limited resources, and uncertainty. So I want to share with you a couple of studies I'm sure many of you are aware of, just to put context to where we're at in healthcare. And I think everybody on this call is probably highly aware, but just to add to that narrative and story, that we have a burning platform to get this right. And so if you look in the upper right-hand corner, this was an article in the last, I think, few months that came out that if you're in primary care, what it really told me is you have an impossible job. It would take more than a day for a single individual to actually do all the evidence-based practices that you're supposed to do. It gets a little better with teamwork, but it's still a very hard job. And then if you look in the bottom left-hand corner, if you're in the inpatient space, patients are getting more complex. And when I look at the staffing models, they haven't changed too much since I graduated from residency. And then adding more to this conundrum that we're facing, many conundrums, is that there is increasing burnout and pretty high intent to leave jobs, which means that we have an unstable workforce across healthcare. So we have to start getting this right. And then thinking about conflicting goals and missions, we just were fortunate to get our work published in the Annals of Internal Medicine. And what we also saw there is our academic medical centers. It's exciting. We're growing, getting to serve our communities. But at the same time, what that is doing is it's causing a supply and demand mismatch with the academic mission and the clinical mission. And so we have these competing missions of sorts that are also adding to kind of the stressors that are in the workplace. We got to do a really fun study, and Dr. Sarah Westergaard is also part of this one, yet to be published, but coming out hopefully in the coming months, where we looked at perceptions of organizations. And I'll talk about this study towards the end of our talk. But when we asked people about their healthcare organization, if it prioritized clinician health and safety, and this was 32 organizations, only 6% of people said to a great extent that their organization prioritized their health and safety. And similarly, my organization encourages transparency and accountability in decision-making, only 9%. And in the far right, I've witnessed instances where it's administrative decision-making, and administrators can be clinicians too, so I'm one of those, has led to adverse patient outcomes in healthcare. 85% said to some degree, to a great extent. So there's a lot of problems lurking in our healthcare organizations that we have to start to address. So that's the negative part of our talk. And now we're going to get to the future state and how we're going to really change the world together. And we're going to explore a novel framework for creating and sustaining effective workplace practices. So the model is simple, and it really stems, I would say, from both quality improvement and kind of occupational health frameworks, which is our work models and work environments, plus our work processes, drive our work outcomes. So as we think about how we improve length of stay, how we improve mortality, how we improve burnout or the financials of our organization, if we don't get the left side of the equation right, we can never hope to get the right-sided work outcomes that we want. And so we have to start thinking about structure and process in every decision that we make. So how do we start to advance the science of work and implement best practices? And I'm going to turn it over to Angela.
So in order to move towards the most evidence-informed operational practices, or really any sort of clinical operational science question, we believe that a holistic assessment of your operational practice, our operational practice that we're interested in, requires multiple sources of data, multiple types of methods, used very rapidly and very iteratively to move towards that evidence-informed practice. Next slide. So in our toolbox, and you could also add any of these to your toolbox, we have methods and approaches that we've applied over the years to these clinical operational science questions. We use tools, and some of these I think you see in research, traditional research, and some of them you see in quality improvement. And we've pulled from lots of different areas to find those methods that work very effectively with these sorts of operational questions. So we use everything from rapid qualitative methods, workflow analysis, to performance measurement and feedback tools like EHR dashboards, real-time EHR dashboards. We've used long form surveys to really get into deeper insights, as well as shorter surveys like ecological momentary assessments, where we really want to know in real time those insights while individuals are in the context that we're interested in, while they're working in a clinical setting, for instance. Next slide. So using many of those tools in our toolbox, striving towards those evidence-based best practices for work, our strategy has taken both a scientific approach and a pragmatic approach, with the goal of building evidence around workload and around work practices. And so we sought to ask questions about whether there are sort of the best measures, the most salient measures. How do we collect those data? Once we know what we want to measure, how do we get those data efficiently, effectively, and accurately? And then what are the outcomes that we're really trying to move? So starting with exploring the measures, we wanted to understand if there were already standardized measures. Maybe there are things in the literature, maybe there are measures that people are already using that are important. What do experts think? Is there expert opinion about what we should be measuring when we're looking at workload and work practices? And then finally, are there any innovations around emerging best practices? Are there things that we could bring into this question that maybe are newer to the scene? Next slide. So our first stop on our journey to understanding measures for assessing workload and work practices was a literature review, which is a very pragmatic, practical way to start, any kind of operational clinical science endeavor. We opted to do a deeper dive and we conducted a scoping review. In our initial poll, we found 6,434 articles, and after quickly reviewing those, 5,375 were irrelevant. So most of them were completely irrelevant. What we did find among the remaining pieces of literature is that there were many measures of workload, but they tended to fall into buckets like RVUs and time and encounters. So like really counting things. We observed some in the literature, some innovation, some practice transformation, like looking at how much electronic communication people were engaging in. So essentially there were lots and lots and lots and lots and lots of articles, but no clear answers on the optimal practice. And what we did see in the literature is that there were impacts on patient safety, on clinician health, and on institutions. Next slide. So the next stop, it's actually technically they were concurrent stops. We did both of these things kind of at the same time, was talking to experts, which honestly, in my opinion, it doesn't matter if you're working on a more traditional research project, if it's quality improvement, or if you're engaging in an operational science endeavor. Talking to people, talking to key informants or experts is one of the most important steps. And that can be as simple as an informal conversation with people who have direct experiential knowledge about the topic that you're trying to understand, or it could be as structured as something like a Delphi panel, which is what we opted to do. So we recruited 17 different experts. And by experts, these are people who have knowledge, who have deep experiential knowledge of what we're trying to understand, and not so much people who are published or, are publicly known experts. So we talked to frontline hospitalists, we talked to people in positions of leadership who are having to make decisions about how to measure work. We talked to a human factors engineer from NASA, which was awesome. And we even talked to somebody from Joint Commission to understand how that person's expertise in evaluating hospital quality, how that would figure in. In our first qualitative round, we collected 135 qualitative comments. And from those 135 comments, we distilled 192 unique measures using content analysis, which is a few too many to actually measure. Next slide. So in round two, from those 192 measures we extracted, we asked our expert panel, our Delphi panel, to score each of those, to rate each of those 192 measures in terms of relevance. And in that second round, our Delphi panel came to consensus about only 6 measures to start with. So there were 6 things that they felt were highly relevant. And they, included things that fell into the domain of scoring systems, well-being and culture. Productivity did show up. Work RVUs are important. We do need to count them, but perhaps maybe not the only thing. And they included some modifiers, so things that we need to think about that, we may not directly measure, but would affect workload for somebody. Next slide. So in our third and final round, what we did is we took the remaining measures. So those measures that our panel, our Delphi panelists could not find consensus about. Either they weren't relevant at all, they weren't, highly relevant, or they weren't relevant at all. So the things that were kind of in the middle. And we asked them to re-rate them. And in that third round, they found another 25. There were another 25 measures that that they considered to be highly relevant. And, you see there's a few more things in the productivity bucket, a few more things in the financial bucket. But then they also added some concepts in the workload bucket, like pajama time or rates of multitasking. They added something in the quality and safety domain, diagnostic error rate, and then job performance. And I actually think this is a really, I don't know, it would be amazing if we could measure this, but how likely would you be to refer a family member for care by this clinician was one of the measures that they ultimately felt was highly relevant. Next one. That said, returning to our original belief that talking with people, talking with those who have the direct experiential knowledge that you need about your topic or question, I would say the most powerful insights that we received did not generate specific quantitative measures that we would, that we could apply, but rather sort of holistic understandings that we've incorporated into our mission to understand hospitalist work. So in the upper right-hand corner, I've been wondering about populations that need more time from us to provide the care that they can trust. While identifying populations seems like another type of stereotyping, perhaps we should start assuming that some patients deserve more time and therefore should be counted twice for in our census. Or in the lower left, I mean, you hear this all the time when you're trying to figure out how, what quality metrics are you going to follow? What other, metrics are you going to follow? But ultimately, the measures that we do follow have to be within the locus of control for each individual hospitalist. So we've taken these insights forward into our work. So after taking our deep dive into the literature and talking with those key informants that we included in our Delphi panel, we learned a few things. We learned that traditional measures are insufficient. So work RVUs, counting the number of encounters or patient volume isn't enough. And that in fact, we probably need to be measuring more than just workload, but we need to be thinking about how our workload and our work environment affects our patients, our workforce, and organizational outcomes. And ultimately, to be as holistic as would be desired and to also include measuring outcomes, we need a more comprehensive and nuanced approach to really address this question. So thinking back to those tools in our toolbox, those methods that we might apply to any of the operational clinical science questions that you might have. I want to quickly talk about one of our absolute favorite methods. We did the scoping review and we did the Delphi panel with our specific workload project, but throughout that process, we conducted numerous rapid qualitative analyses that sort of have added dimensions to this, to our mission of understanding work and work practices. So to accelerate our work on work and to encourage innovation, in addition to those highly structured approaches like Delphi panels, we also use rapid qualitative methods for collecting, condensing, and analyzing qualitative data. This method is highly accessible to anyone, really. If you've never done qualitative analysis, you can do rapid qualitative analysis. And it's really well suited for evaluating operational practices because the intent of rapid qualitative analysis is to generate real-time actionable insights that you can use to answer your question to move your mission forward. Next slide. So in addition to the various methods that we've used, we also have leveraged our relationships. Innovation in a vacuum is lonely. I personally wouldn't want to do that, to work on my own, trying to answer my own question. And I think it's potentially less likely to produce like the deeper insights we're looking for. So to really advance our understanding about work and work practices, we came together with our colleagues across the country as a part of the Home Run Research Network to form a workforce affinity group. And we started our work in 2020 with COVID, trying to understand COVID surge adaptations. And since then, it has evolved quite a bit. And we've tackled questions like, what are the workforce priorities in hospital medicine? How do jeopardy practices affect people? all the way through just recently published in the American Journal of Public Health, which I'm so proud of because I always wanted to be in that journal, an evaluation to try to understand leadership in worker safety, shared leadership in worker safety for hospital medicine physicians and APPs. So we've used all of the methods that we've talked about: rapid data acquisition, rapid qualitative methods. We've used surveys, and we've disseminated those learnings across different, using different methods, not just publishing, but across different methods to get our words out, our findings out to the world. So in our continued drive towards best practices for work load and work environment, applying what we've learned from the literature, from talking to experts, either with our Delphi panel or using rapid qualitative methods, with insights from our workforce work group, we have designed an application that we call Gritty Work. And the goal of this application is to facilitate rapid real-time data collection to understand workload and perceptions of work directly from clinicians while they're in the context of work, while they're on a clinical shift or at the end of a clinical shift. So we've designed and tested this mobile application, and it collects everything from more objective measures like how many patients did you see today? How many hours did you work? How many units were you on? We collect those objective measures. We're actually seeking to try and figure out if we can get those things more passively so that we don't have to ask people those questions. And really then we can focus on the more subjective perceptions of work using things like the NASA task load index. How mentally demanding was this shift? Physically demanding? How hurried or rushed you were? In addition to asking people just with a really simple, happy, sad face, you know, how was your shift? Was it a good shift or a bad shift? Excellent. So we first spent several months building our Gritty Work app and optimizing it. And then once we sort of had it in a pilot state, we conducted a pilot with clinicians who are on service, both APPs and physicians at the University of Colorado Hospital. And those 30 clinicians used the Gritty Work app for 4 days out of a 7-day stretch. It ultimately ended up being like 122 shifts. And we learned quite a bit from our clinicians during this small pilot. So some of the more objective data, you know, number of hours worked, an average of 10, number of patients that they're responsible for. We asked 2 questions: how many patients were you personally responsible for, and how many patients was your team responsible for? And those numbers are slightly different. How many units did you travel to? So 4 different units in the hospital. And then we asked some more subjective questions. So what was, we calculated the NASA task load index. So that is value is a mean of 44. And to give you a little context, 0 would be there was absolutely no workload or task load involved in whatever it is you're trying to evaluate. And 100 would be like the absolute maximum task load. So a little less than, you know, midpoint. 44% of individuals felt like they always had the things that they needed. 88% felt that it was a happy shift. And 89%, you know, from the AHRQ Patient Safety Culture Survey felt like they were working together as an effective team. Only 28% of our individuals reported feeling burned out, but this is probably like a biased sample of people who were interested in helping to try out this app and maybe like a little less burned out, because I think that's pretty low compared to the literature. Next slide. True to form, we of course asked people in qualitative interviews what they thought about our Gritty Work app. And in terms of the design, they felt it was easy to use, that it was an understandable interface and intuitive. They would have liked maybe some instructions or guidance on the more difficult questions. In terms of user experience, and this is probably my favorite finding that we uncovered in those interviews, is that people told us that completing the survey at the end of the shift was kind of cathartic, kind of therapeutic, and an opportunity to reflect. which was I felt like a somewhat unexpected finding for us. We are trying to figure out, based on some of this feedback, what the optimal number of survey days might be to truly capture workloads. We don't have to survey people every day for any period of time. And then finally, in terms of implementation, it's not enough to have a beautifully designed application. You really do not need to have a strong culture, a safe culture for people to feel like this is something that they can do with a sense of psychological safety. And that there needs to be a clear purpose. So why are we asking people to complete surveys on a regular basis, so that we might tie those results to improvement initiatives to really make that connection for people. So now I'm going to turn it over to my partner in crime, who is going to take us home, take us over the finish line about how we might build this beautiful future of work.
Thank you, Angela. All right, so now we get to the key question about how do we think about driving outcomes and what are the outcomes when we build specific work design strategies and staffing models. And so the way we have approached this in our work is we think about more than clearly productivity. We think about productivity, and we also think about what are the people outcomes. So the work outcomes, the patient outcomes, safety, quality, and organizational outcomes. And at least the way we think about this is if you don't have each of these key outcomes in your vantage point, then your strategy is not going to work. It cannot only be financially driven. It cannot only be about workforce wellness. It has to be about all of it. And so we've really started to think about how do we build those evidence-based practices. Much of what we've been showing you is the foundation to that approach, really integrating a data-driven approach to everything that we do. Thinking about passive data acquisition, which I'll share with you some strategies that organizations can actually do and are doing today. They just may not be aware of it. And then thinking about how we bring in the active viewpoint of the clinician and take advantage of the patient outcomes that are already in the electronic health record. And so really harnessing all the power that is in our EHR, and then taking something that's called a total worker health approach. We cannot forget about the workforce as we try to do these optimization efforts. It's a core part of like what we do. So today, anybody who's taking care of patients within Epic or any other major electronic health record system, in the background of that electronic health record is clickstream data. So as clinicians, when we're typing away, doing notes, viewing different aspects of a chart, all of that is collected in the background. And that started very early on, actually, when the electronic health record systems were created as a means of monitoring who's accessing charts and should they be accessing charts. But increasingly, this data, which is called event log data, or you might hear the term audit log data, this data can be utilized to understand work patterns. And then those work patterns can then be looked at to see what outcomes do those specific work patterns drive. So this clickstream data that you can see essentially, or event log data, audit log data of a hospitalist here. We have Epic at University of Colorado. And so you can see that this goes as a couple of weeks or a week of data, I believe. It rings true. So as a clinician, you come in around 7 o'clock, you're reviewing data, the latter part of your day, you're doing notes. You can see the dip when we're actually doing rounds. So it's a really cool data approach that takes no additional action other than just doing regular work to start to understand what are sort of the footprints of work look like, and then what do they drive. And increasingly, there's some cool studies that are starting to link this to like burnout and other outcomes. So our big dream then is to think about how we integrate something like gritty work, pulsed brief surveys of clinicians to understand what you can't capture, being thoughtful about the survey burden because we don't want to add additional burden to folks. And then thinking about how we can collect and integrate that event log data, clinical outcomes data into what we call, really the dream is a safety management platform, so that we can see proactively when workloads or work design, say you implement something new, is potentially causing harm and or better outcomes, so that we can be much more proactive instead of waiting, a year or two from now to find out that, 80% of the workforce is burned out, or that a staffing model is actually leading to patient harms. So this is the dream that we're actually aiming to implement and starting to implement in real time in our operations work at University of Colorado in the coming months. So I want to shift a little bit. We've talked a lot about how do we build evidence-based practices, But a key component of implementing evidence-based practices and building them is that you also have to think about organizational decision-making. And we've learned a lot in our work and thought about who are leaders that make decisions. And every single person, I would bet, on this call has some sort of leadership role, whether it's formal or informal. If you sit on a committee and you have a voice, if you're leading a care team, you are a leader. And we have to think about how leaders who make operational decisions do better. And so we've done a lot of work and a lot of thought about thinking about how we start to minimize a term that was coined in the New England Journal of Medicine called administrative harm. And administrative harm is not just about administrators' decision-making. It is about anyone who is in a leadership role, clinician, administrator, AL, everyone who has influence over operational or larger decisions that impact resources, staffing, et cetera. And we have to start thinking about how those decisions impact care very similarly to how we do in the clinical care setting. We know when we make patient errors, we do look backs, we understand, and we grow. But that type of decision-making and assessment does not exist, or at least I haven't seen it. And in our work, we haven't seen it when we make high-level administrative decisions. It doesn't even have to be high level. And so we got to interview individuals from about 32 organizations to talk about the concept of administrative harm, which I think the concept is new, but what we heard from those who were in the focus groups is that this concept is pervasive. Term is new, concept everywhere, but we have to do better. And what we also heard from people is that our organizational cultures and the lack of psychological safety drive the inability to actually learn from our decision-making. And the higher up we get in leadership roles, the more blind we are to understanding what the actual harms are, or even positive outcomes to our decision-making. And we learn and know that decisions impact work structure, processes, resources, everything we know and do in work. And then the front line, the folks who are doing the actual work, have to do workarounds to try to get around some of the decision-making that may have been less ideal in the first place. And so as we start to think about implementing and what are those evidence-based practices, then we also have to assess, is what we thought true and what was the ultimate impact of those decisions so that we can continue to get better and better, not only at clinical decision-making, but our organizational decision-making. So I want to circle back very briefly to the $11 million question. And as you all know now, I thought it was a $12 million question. So we've talked a lot about clinical operations science, which may be a new term, but hopefully, as you see in your day-to-day work, these problems, these pain points, that you can quickly shift those questions into productive ways of thinking about them and even research questions to start to build an evidence base where there is no evidence today. And then as we start to build that evidence, we have to think about how we implement that into our organizational decision-making, and then how we make better decisions and that we continually evaluate them so that hopefully I and you never have to have like those frictiony conversations around whether you need $12 million or $11 million or whatever the money amount is to ensure sufficient staffing so that patients and the workforce and organizational outcomes are better. So we will conclude and look forward to lots of conversation and questions, and just want to say a quick note of gratitude. Thank you so much to all of you for your attention and for the invitation to share our work and ideas. Thank you.
Great. Well, thank you both for a wonderful overview. And I have to say, Marisha, I was very amused. So I knew Rick Albert before he went to Denver, and he was the person I always think about with a long white coat and a tie. So quite amused. So one of the challenges, I will kick it off. You know, a lot of the metrics you're talking about, parameters of productivity work, are hard to capture. And when we talk about SMART goals, for example, how to make them measurable and reliable. So how do you develop something measurable, easy to capture around, you know, many of the things that you listed?
Yeah, I think in our world, I think we think most of it's capturable. And so I'll just use an example. We recently built a virtual hospital medicine program, and that is about as non-traditional as it gets. So you don't generate RVUs in the traditional way. There's just a lot of like non-traditional stuff about it. But we really, because it was new and there was a lot of uncertainty around it, we're like, we have to assess this in a very real world kind of way. So we utilize gritty work questions. And then we're actually going to bring in the audit log or event log data. So you get everything. So we got, there were a couple of weeks where people were not happy. So we got frowny faces. And that was like a direct indicator where we're like, okay, there's a problem. And what's the problem? And take a deeper dive. And then looking at quality and safety outcomes. So we got that data in very real time, weekly, actually. And then you get the event log data like the second it happens, if you want to pull it. And so I think the question is understanding, as Angela was showing, there's almost too many measures. And so our next goal around some of the grants that we've been submitting is how do you go from like way up here, hundreds, thousands of measures is what it feels like, to what is the most important, because not everyone has a data and analytics team. Not everybody has access to data. So how can everybody get this data to make better decisions? That's our dream.
What are those most salient things, those 10, 15 things, and how do you get them in a flexible, efficient, easy way where you don't have to find a data analyst to dig it out for you?
Right.
We believe this is possible.
Thank you for a great talk. I wanted to ask a follow-up question. I think one of the things that stood out to me from the gritty work pilot was that even though, as you said, the sample was relatively low in terms of burnout, yet still the majority of responses that they did not feel like they had the essential
Right.
skills and so forth, which I think is really concerning as a hospital medicine clinician to feel like that on the wards. So I wanted to see if you had kind of follow-up kind of qualitative interviews or other data about what sorts of kind of things were driving that and kind of next steps potentially from that.
We do.
Yeah.
So do you, yeah. So but if you want to pull, I don't know if you have the comments readily available, but we, so that what's nice about the Gritty Work app is we do have an open-ended, like unstructured question to capture some of that, because people might say they didn't have the essential supplies that they needed, and they might say they had a bad day, but that doesn't tell you why. So we did collect some of those data, and I don't know, Marisha, if you have that at hand.
Yeah, I don't have it in a slide. I do think that question is also nuanced, right? So it's always, right? And then if you actually were to go down a notch, like majority of time, people did have what they wanted, but it's never always. And so, but it's a great point. And so we've often, as we were developing gritty work, we're like, we can't forget the comment box, because people will put, very specific things. And then we try to keep it safe. For example, with the virtual hospital, it's like, I don't personally get to see what people put, because they sometimes put identifiable data and we want them to think it's safe and for it to actually be safe. So only Angela and team get to see that data, and then they will take it down a notch so that there's that psychological safety that, man, you can fly off the handle if you want, and you can talk, about Dr. Burden if you want, whatever you want to say. It'll be in a safe way. And then we'll distill that down to actionable insights.
And people do give comments. I mean, they feel safe and comfortable doing that. They will tell you why. It was a bad day. And a lot of it is, coordination and communication issues or system issues, like those things that make a complex patient a little bit harder.
Great, thank you. We have a question in the chat from Dr. Trowbridge, who is a primary care doctor or division chief within general internal medicine. And she wanted to note whether your work has looked at studying what the optimal teams and kind of rations for teams are, and kind of who's included in the team.
So in all of our work, we do include team-based questions, but I will say what's really exciting and cutting edge. So we don't have an answer yet, but it's something we deeply care about, because we have a very amazing advanced practice provider, physician, collaborative care model that we love. And we want to share with the world how great that is. And so we're like, how do we capture that in a data way? But event log data and audit log data. So there are teams across the country who are actually starting to study, how do you look at teams electronically to understand which team and composition of team actually drives best care. And there's actually a study looking at care of stroke. And so when people have like known relationships, previous relationships with each other, the care is better and faster, not surprisingly, right? But I think that's where we'll see a lot of this team-based care work coming from, using this electronic data that is readily available. It's just massive. And so trying to wrangle that data, I think, is going to be the key. And that's hard for a lot of places where you really have to have that data expertise to do that.
But in theory, since Epic has already created Epic Signal, which is a distillation of a lot of that audit log and event log data into something digestible, which is the figure that Marisha showed, if we can say like these data points from event log data are most helpful for understanding work practices and what drives the best outcomes, why couldn't those things also be distilled into this more digestible format that people can access if they, whatever they like, whatever their position may be, whether they're a leader or a frontline clinician.
And well, I guess I'm wondering, Betsy, if that answers your question, because I interpreted that question a little differently of like, what is the team composed of on the inpatient side and or the outpatient side? Do you have a hospitalist? Is there a nurse, a physician, APP, the ratios? And then do you have metrics to measure the patient severity of illness to the team, et cetera?
I think we're still trying to figure out the answer to that question, although we have a colleague at Indiana University who did a study with a health economist, and they determined that there is sort of a ratio between number of patients and complexity that drives length of stay. So you have to have a balance of the right number of patients and complexity to lower length of stay. Yeah. So that's like the one study I think that's really come out in that space yet.
Yeah, and I think our goal is really to determine what are these like break points, right? Where you never get to a break point. Like you want optimal staffing, right? But never to get to the point of decline. And I think some of the work that we also will have hopefully coming out, not only is it like complexity and number, there is like multiple studies in the hospitals world, at least where, and it's usually like 15 patients, but these are older studies, right? And so we know complexity is increasing. But right. Another fun finding in one of our recent studies that's yet to have been published yet is also experience. So when we talk about the cost of turnover, like if you want to lower length of stay, having a more experienced workforce actually contributes to lowering that, which really it results in dollars saved to organizations. So I think, what we're learning in this work is doing right by the workforce so that they can do their best work is central to making an organization thrive financially and otherwise.
And then, Betsy's follow-up question is the Gritty tool available in the ambulatory setting and applicable for that?
We haven't tested it yet in the ambulatory setting, but we 100% believe that Gritty work should and could be used by any clinician, any provider in any setting. So we'll have to do further studies to validate it because we think the questions will probably be slightly different. We're currently working on a project to understand like what might those questions be for residents in a space where residents would use Gritty work for inpatient work. And so we're getting there. We'll get there.
And Betsy volunteered our group to pilot, apparently.
Email us and we will be happy to include you in the
100%.
And I'm just curious also, you're focused on hospital medicine. And I think, as an intensivist, it's kind of a parallel, but, a lot of the same issues that come up. So have you thought about comparing or deploying the tool to intensivists and comparing to hospitalists and looking at similarities and differences?
Our dream is to have Gritty work everywhere and in every care setting. But I think we started with the world we knew first. And then I think, our dream, and so what we plan to implement in the next month or two is Gritty work goes live across our division because now it's on the App Store. That you have to have a password and stuff to get to it just yet. And then to start to understand, okay, in hospitalist world, if you're on a teaching team, what's the cognitive load? If you have X, Y, or Z learner type, what's the cognitive load? What's the experience like? Because the other conundrums just internally that we're trying to figure out is, and as I alluded to with our annals paper, our team dynamics, even in this little world of hospitalists, they're shifting. And I think thinking that all teams are the same and every team maybe has the same cap or structure may not be the best approach. And so trying to understand even the nuances within a specific team, what drives the best outcomes from a workforce, learner, et cetera, is really hot on our list to do in the next month or two. So we're trying to roll that out in a big sort of operational way.
And to bring in that passive data from the electronic health record so that we don't have to ask you how many hours you worked or how many patients you took care of, because we have those data passively, and we can get your perceptions as a clinician on those things that we would not be able to get out of the electronic health record.
One question from one of our hospitalist colleagues, Dr. Sturkin, was whether kind of about the intersection between nursing workforce factors, and he specifically mentioned the kind of concept of unionization, but one can imagine there's other things that kind of have to do with nursing workload and so forth, and then how that intersects with other team members, hospitalist kind of workload, and kind of any efforts to kind of investigate that.
Yeah. So then the cool thing about the electronic health record, anybody who accesses it, we can get this data. And so I think we're starting small, because like it's a big project, just even starting small. But you could imagine that everybody has, like, at an organizational level, like, how do these things interconnect? Because most certainly they do, right? If nursing is unstable and you're having to bring in folks who are less familiar with the organization and processes, that's going to impact the happiness of your hospitalist or other specialists. So it's very interconnected. I think it's just going to take a little bit of time to get there to really integrate that. But yeah, it's a huge voice. I think any and everybody who you interface with at some point, the dream would be to interconnect all of that.
Okay. Right, I think we are at the top of the hour, just about at the top of the hour. So thank you again, and we would be delighted to have you come in person. And we will have cheese curds and maybe some ice fishing, but actually we haven't had ice fishing this year at all.
That's
Well, this
fun.
is wonderful. Thank you. Thank you so much for letting us come and talk about our passion. We appreciate it.
Thank you.